We have Kimberly Armstrong from Spectrum Works in Canada, and we'll also, after Kimberly speaks, we'll have a video from Wenn Lawson from Curtin University in West Australia, and they're going to speak to benefits of late autism diagnosis and self-recognition in older adults.
Yeah, so I've been struck as we've been sitting here talking about all these different discussions about how relevant this topic is to everybody else's topic, because when we're thinking about creating health passports and earlier, interventions, it all requires that we do identify autistic people, and as you pointed out earlier, 9 in 10 over 50 are not identified, and so that's a big challenge. And thinking about what Hedda had written earlier about sometimes people aren't referred to even get an assessment because healthcare providers don't think there's any benefit. So in addition to having the benefits to accessing healthcare, as a clinician, a clinical psychologist, we can see that there are so many varied benefits that are almost unpredictable based on each individual person, and those benefits are going to be different. So I just thought I would share quickly one case from recently that might kind of highlight this. So a few months ago, I diagnosed a woman with autism who was in her 70s. She's an intelligent woman with great insight. As evidenced by her seeking out a diagnosis of autism at her late stage of life, before many people would even recognize that as a possibility. She had accumulated, like most people who are diagnosed with autism later in life, had accumulated a laundry list of previous mental health diagnoses that did not necessarily, she did not feel fit her full presentation and struggles. She had held on to long-standing resentment and sadness actually about her family's move across Canada when she was a teenager, and had kind of gotten sucked into this hole of feeling of sadness about that, and had already planned to move back across Canada as soon as she graduated, which would have been about 2 or 3 years later. She had developed some fragile social connections as a teenager and was very upset when those were disrupted. As well as her routines and familiar environment being changed. Her mental health had worsened, and after graduating high school, even though she'd planned to move back, she never did. When I gave her the news she was autistic, she was quiet for a minute and looked up at me and smiled. She said although she would have preferred to receive her diagnosis in her 40s or 50s, she was so grateful to have received it in her 70s rather than not at all. A few weeks after telling her she was autistic, I spoke to her again, and she told me she was finally going to travel back across Canada to see her brother, who she hadn't seen in over 50 years. She spoke of feeling utter relief at having an explanation for her whole life, and this is not unusual. In fact, clinically it seems that the older the client is, the more relief they express when they are diagnosed. So some of the questions that I had were, why did this woman suddenly feel like she could travel back across Canada once she got her diagnosis, but not before? How does receiving a formal diagnosis or self-identifying as autistic later in life change one's understanding of themselves? How does it change how others view them? How does it affect their mental health? Does formal diagnosis versus self-diagnosis matter? Perhaps for health passports it might. What are the main barriers to diagnosing an autism diagnosis or assessment later in life? And there are many, and that varies depending on where in the world we are. And beyond the benefits to the individual person, how can the identification of autism in seniors benefit society as well? Can it allow for the unique gifts and talents of autistic people to be better recognized and used? How can we conduct research on autism and aging when so few seniors have been diagnosed, and the ones who have represent a select subsample of the population? Certainly in Canada, it's people who can afford private diagnosis in some areas. And what supports through local medical systems, the community, and internationally can best support individuals who do not have access to diagnostic services?
So before we jump into discussion, we're going to share Wenn Lawson's video. So if we can bring that up on the screen.
Hello, my name is Wenn Lawson. I'm an Australian person living near Melbourne in Victoria, and I'm an older autistic person currently going on 74 at my next birthday. I'm taking these few moments just to share with you some of the experiences of being an older autistic person when the world, at least the world where I'm living, is mostly equipped for young autistic people. Services are geared for much younger people. As you get older, the needs that you have change, and yet services don't change in order to meet them. So just to share with you some of those sorts of things that happen for me as an autistic person, some of the sensory things that I live with. I'm wearing tinted glasses to help with some of those sensory things. That they help with keeping lights from not being too bright. I also wear a cap to help with that as well. And places like doctors' waiting rooms are more frequently visited for older people. And yet they're very sensually overwhelming, with lots of people, lots of noise, lots of activity. Being mindful of those needs is really important as we address what older autistic people need in policy and in practice, educating medical practitioners so that they're equipped to work with us is so important. Whether that's in the emergency rooms, whether that's in GP places of medical attention visited, whether it's hospitals in general, it's so important that our needs are understood and accounted for. And that means listening to autistic people. We're all very, very different. Some of us are quite verbal and can speak, others are not able to do that. So having typed messages, someone who will work with them to write out what they need, or having this presented in picture form in whatever way. These things may be made publicly available to medical professionals in information that's visual, printed, and shared between them and with autistic people is vital. So I will just stop there, and hopefully this makes sense to you. Thank you.
Okay, so we'll open up for discussion or questions. Abba?
You talked about the diagnosis at the age of 70. So were the symptoms very mild and like daily activity, daily life was not affected? Like if they missed the diagnosis for so many years, so was it the symptoms were very mild?
Yeah, it's a good question, and I can speak to maybe more broadly the clients that I see that are in their, I would say, 40s and above, mainly, and they're not necessarily mild, actually. Some of them are. They would all be classified as level 1. But for example, I diagnosed someone recently in their 50s, and I gather report cards whenever possible because often they don't have parents reporting on when they were younger. And their report cards read like a DSM diagnosis almost. So I think our change in perspective has really, if we think where we were 50 years ago, 60 years ago for some of these individuals, they may have presented as more obvious symptoms actually, but just never got diagnosed. And then the older that they got, the less likely they were to be diagnosed, even when our understanding of autism expanded.
I just wanted to talk about that point about the levels. One of the things I'm trying to help professionals understand is that the levels are not constant. I have a joke I tell about trying to pre-board a flight, and they said, "You don't look autistic to me," and I said, "I'm about to." The levels are subjective observations of our internal experience, which is far from mild. And in my experience, having been diagnosed at 40, I was autistic my whole life. I was punished. I was stigmatized. I was abandoned. I was abused, I was neglected. And none of those experiences are journeys that anyone wants to go through. And so it's kind of problematic for me when they suggest that people who present more internally, and I use that to project that our internal experience is just as profoundly impacting if we can or cannot contain it. It's the same. The difference is we are containing. We're enduring the same struggles, but we're containing. And the cost of that containment is what we're seeing in adulthood. The stress hormones, we're seeing dementia, we're seeing mental health breakdowns. The other thing is many autistic people who present more internally are fairly sheltered their whole lives. And as a result of that, they don't come to their diagnosis until they hit their own personal wall. It can be middle school, it can be graduate school. For me, it was having 2 neurodivergent children who never slept at night, going back to our friend's comment about sleep, and the chronic sleep deprivation led to me having to go get a diagnosis. So this is why I'm in alignment with it all being autism. I think that to project that some people's experiences are more impacting because they do not demonstrate, or because they demonstrate externally, is a misrepresentation. If anything, I'm a little jealous, because anytime my autism expresses itself externally, I don't get, are you okay? I don't get, do you need help? I don't get, can I help you with something? Are you doing all right? I get punished and abused because I'm supposed to contain it. And the harm of that is pervasive throughout the lifetime. So, you know, I'm preaching a little bit here, but I come from Kentucky and we do that. I went to college to be a Methodist minister because I like to preach. But all to say, I think we can do better to remember that the levels were not created or informed by autistic experience. And it really does great harm because services are directly connected to those levels. And that's so unfair because I know so many people who are intelligent, articulate, have gone through schooling, who have intermittent employment, who are suffering greatly because of their outward presentation of autism, leading you to believe they need less. And there's no evidence of that. The evidence is showing us completely the opposite. Sorry to preach again. Thanks.
Can I respond to that just quickly? Oh, sorry. I just wanted to say I totally agree with everything that you say. I actually say all of those things when I give diagnoses to people, and I don't actually give any level to anybody except for in the report. So I don't necessarily say it. I will. Many people ask me, and I say exactly what you say, and then I say, so based on that, this is the level, but so arbitrary, so subjective, so interchangeable, depending on the environment, and also interesting to hear that it's tied to funding, because in Canada it's actually meaningless right now. So yeah.
I wanted to come in and say I could not agree more strongly, Dana, with what you said. I mean, our experiences are so changeable and so fluctuant, and our support needs are so dynamic. But what I really am starting to realize and talk a lot more about, and particularly as I move into this stage of allowing my autism to show, it feels horrible. It's not nice because, and it's linked to some of the work that I'm doing at the moment with autistic psychiatrists, which is so important for mental health of autistic people. The overarching reason why autistic psychiatrists don't disclose is shame. It's why we don't let our autism show. It's why we try and mask. And I'm, losing the ability to mask sometimes. But I have I've written about this idea of weaponized heterogeneity. And that's what's happening when people try to split us up into groups. We're not 2 separate camps. Qualitatively, our experiences are so similar. I go to a conference for non-speakers, or I spend time with, non-speaking autistic people with intellectual disabilities, and I resonate in ways that I would not have expected 10 years ago. And it's difficult to articulate, it's difficult to understand. But autistic people know this. We know this. And why it's important is because autistic people with the highest support needs are the most marginalized and have the greatest needs. And yet, those of us who can articulate our internal experience can perhaps shine a light on some experiences for those who can't. And autistic people who can't speak, when I talk about this, they say, we have so much in common.
So we have a guest, and we have about 30 seconds, so go ahead. Yes, yeah.
On? Okay, I just want to say, first of all, the last thing you said, as a speech pathologist, communication specialist, AT, what I've seen is a need for mentors. And I've talked about that. I work mostly with the non-speaking. But what I wanted to jump in and say is the gap between leaving school for the more impacted and adulthood, I'm seeing such tremendous needs. I keep in touch, friends with many of my students. The occurrences of increased health needs is dramatic. We have had to, and this goes back to the passport, we need multimodal supports. We need visual supports, we need written supports, and we need communication specialists. My friends who are spelling through STC or rapid prompt, or they still need a communication support person there. They cannot go in and, as you know, with they cannot initiate. They need, as their plan, they need somebody who can be sort of like a sign interpreter, but a communication support person. And I just want to add, because I know I'm talking too much. Okay, all right, no problem.
So we're going to turn to Alistair de Gaetano.
Did I turn it off?
Advisory Council Malta, who organized us here today. And Alistair is going to talk about financial vulnerability, precarity, and support for exercising legal capacity.
So yes, thanks a lot. So first of all, I'd like to thank the organizers, Autism Research Institute, Nancy Lurie Marks Family Foundation for also supporting this event, and also my colleagues Victoria, and also colleagues from the mission, Rachel and Francesca was here earlier, for their continuous support, not just with this event, to actually allow us to, from time to time, as Malta, support such initiatives and bring such an amazing group of people together to tackle these matters. So we've heard a lot from the medical perspective, the allied health perspective. I will speak from the legal perspective. I'm autistic myself, but I'm also a lawyer by training. I work in policy. And one of the things which we've actually worked on also was in Malta, the issue of legal support. So support for autistic people and vulnerable people, mostly with disabilities, to be able to exercise their legal rights, their legal capacity, but also how current structures can affect people and leading them to also situations of double discrimination, increased vulnerability between accessing services, accessing care and support, and also being in a predicament that also affects their possibility when it comes to income. I mean, one is linked to another, and it all comes down to, we've actually heard a number of speakers mention this, the medical model as opposed to the social model of disability. Because I believe that the way we actually look at people is usually the way that translates in a legal system, and if we're already looking at people as broken, just looking at the medical aspects, Madina, Mary, were actually speaking about the fact that we actually have to prove how disabled we are. That's why I prefer to speak about disablement rather than disability. It's a society that is actually disabling us. And if we actually have to prove that we are struggling, then we are looking at how broken a person is, and unfortunately, rather than actually looking at support, we end up at a point where a person like is really at the limit, and then when a person like gets into meltdowns or whatever, then instead of like looking for their supports, we use the concept of danger to self or to others, and instead we start like using legal instruments such as curatorship, interdiction incapacity, guardianship, and we just make things worse for a person, because like then we like affect the right to exercise a legal capacity, which is also enshrined in international conventions such as the UN Convention on the Rights of Persons with Disabilities, which many countries like say Canada, here Malta, Ireland have all like signed up to. And we just like make situation worse, because rather than actually like offering support to a person, we are saying, okay, you are like not good enough, we can't trust you, we are presuming incompetence. So whether it comes to managing your daily affairs, whether it comes to actually making choices about your healthcare, even if there is a certain level of medical impairment there, or let's say medical degeneration, like with age, let's say an autistic person who also like has dementia or like another progressive condition, instead we are saying, okay, we know what's best for you, it's in the concept of best interest, and we are, as I think it was David Nicholas earlier mentioned it, impinging on a person's agency at the end of the day, and especially when it comes to issues such as financial precarity. There are already like issues with accessing like services, they're like not accessible to autistic people, they're not accessible to any people in general sometimes because of administrative burden. I've seen like Dina and Chan speak about this. But then again, if we also have somebody over and above making financial decisions, so the person's punished for being autistic, especially in their older years when the person's already vulnerable, then we have a major problem. So at the end of the day, it is very important to actually look at what the UN Convention like mentions, even in countries that have not ratified it yet, such as the United States. It is important also to see what the principles behind it are, and understand we're dealing with human beings. An autistic person, no matter like if we speak about levels, high functioning, low functioning. I hate labels because, as Dina was saying, I will not repeat what she said. It really is a very arbitrary like description, and instead let's look at how we can support people, and let's totally think about redefining the rule book. So let's go from substituted decision making to supported decision making, as the UN Convention mentions, because be it like matters of like financial like management, or else be it like other, let's say, issues that have to do with guardianship or conservatorship, we have to have a system whereby instead of a person saying, okay, this is in your best interests, like, okay, if it's like children, it's one thing, the Convention on the Rights of the Child mentions this. But if we have adults, people like who actually deserve agency, like who the law says should have agency, why should we actually strip away that agency? Because we actually feel that they are less deserving than others. The UN has its own rules. There's Article 19 of the Convention. There's General Comment number 5 to it also, which explains a number of concepts, and it says, do not look at the best interest. This is another human being. Look at the rights, will, and preferences of this person. Now, not everyone will be able to express this in the same way, but that is why human support is also like necessary. You can use assistive technology, like there's also, for example, persons like who can support such personal assistants. I myself, like with Victoria here, my personal assistant, who actually like does help me with the barriers which I face, like due to my disability which society has created. I mean, I do not negate the medical impairments that I also have, but like most of this is created by society. And at the end of the day, it's all about like speaking to a person, seeing like what they want, what they need. If a person needs alternative communication like methods, let's see that those are available. Let's see, do not create additional barriers, because in the same way that like we are creating barriers administratively, we're also like creating barriers if it just negates the person the chance to be able to communicate. And also, then if a person like is totally like unable to express its will and preferences, for example, because of rapidly degenerating condition, then we have to look at the best interpretation of the will and preferences. It is something which the Convention mentions. It's very important also, especially even, for example, if you have financial decisions. Let's say have a person who actually like needs to make a will. So we can't just say, okay, look, I think that grandma's like not really, let's say, competent. So grandma always had a good relationship with like these nephews or nieces. But no, I want to decide differently. So we actually have to like decide that you have like to consult the person, and if the person can't be consulted, we have to look at their life patterns. I mean, there is a system in place, but we have to stop like thinking of matters like in a substituted manner. We have like to look at support decision making. We have to look at best practices, countries such as Ireland and Spain that have like implemented this. Even such as Costa Rica, outside of the European Union, have like very good models on this. And we have to look at the twin concept. On the one hand, looking at the person, looking at the agency, and looking at how we can support the person. And secondly, like not just like substituting a person's like rights to decision making, supporting each other, but making sure that we don't put a person in a situation where they have to beg or actually face more abuse, because then we have issues of financial precarity, social isolation, loneliness. So one links to the other. It's all about look at the person. Being autistic like does not mean that we're broken or less, whatever the age, and let's work with a person to be able to make sure that like this person can still participate in the fullest like way possible in society. Finally, one of the very important things is advocacy. Like we've heard, for example, patient navigators. I really love that concept. Patient advocates, we have in the UK. So strengthen advocacy and self-advocacy at all ages, a life course approach. Nothing without us. And needing support does not mean incapacity. Let's also look at the gray areas, because these are usually where there are issues. A person like who might need support one day, not need that much support the other day. So like these people are not broken. Like and if we actually like have this in the law, have a legally mandated like framework, then this would actually underpin a person's rights and the way they'll be able to participate in society. Thank you.
Open for discussion? Comments?
What about like other legal documents like power of attorney or healthcare proxy or end of life decisions, DNR? So who takes care of them?
So actually, it's a very good point, and at European Union level, we'll have a discussion like going on about that, because there is like an international convention. It's called the Hague Convention, the 2000 Hague Convention on the international protection of adults. So even the wording itself is a bit outdated, because we're speaking about protection. Like human beings like need support and not protection. So like nowadays, many years later, we're seeing that there is a shift. However, still, we have to realize like legal realities. So a person may make what's called a mandate in anticipation of incapacity. So it's just like a DNR, for example, do not resuscitate, like order, in which like a person would actually mention, according to the different stipulations made in the particular national law. Okay, look, if these if these criteria happen in future, for example, if I get sick, if I'm no longer able to communicate, then I designate this person or these people or the state to actually take charge of certain affairs. The important thing is this, that was actually freely made by a person when the person had full mental capacity. However, at the end of the day, if there's like other institutes, for example, such as even make a power of attorney, it might actually come as a bit of a surprise, let's say in certain jurisdictions, and say, okay, if the person is not compos mentis, if the person is not like mentally capable, how can the person actually make decisions? But this is the thing, is the gray areas. Many times you either think of a person being fully, let's say, mentally capable, so we equate to being fully legally capable, and that's what many laws actually have. It's a very, let's say, black and white system. Or else, like, as soon as a person starts to play up when it comes to mental capacity, we just err on the side of caution, become paternalistic, and we take that away. The important thing is this, that a person with support, even once they start deteriorating like medically, can still be able to make certain decisions if supported. So what we need is a sliding scale. So be it, let's say, power of representation, which is like made later, be it like any kind of legal instrument. So you have those which are made before, and fair enough. I mean, the person gives the instructions. So the person's agency was not compromised. But it's important that going forward with any kind of legal document that like can happen, you always allow for the possibility of a person being supported. Now, there will be like instances, for example, where a person like is completely unable to communicate in any way. Then, in that case, yes, another person will take over, but still, it will still be supported decision making, but using a best interpretation of their preferences. I know like it just like sounds like different words, but it's different, because if a person just decides on behalf of somebody else, it is substitution. here, even though a person is acting somebody else's behalf, they are actually acting like as if they were the person when the person was okay. And it is a very nuanced difference, but the UN Convention, and this is General Comment number 5, seems very clearly, because I mean, this way, it will also allow for lack of abuse, because it's very easy to say, okay, grandma doesn't know what she's doing, let me decide instead of her. But this is where you actually get to situations where you have people playing around with people's wills. So then again, it's all about either I'm supporting the person, deciding with the person, or as I'm deciding as if it were the person. Going by documentation, so a court will have to look at this. It needs a culture change. It has happened in very few countries. The UN has mandated this, but it should be something we will move towards, especially with autistic people who many times are being silenced.
Thank you, Alistair. So I think we're going to move on, and we have Laura Graham Holmes here from Hunter College at CUNY, and they're going to talk about learning from other sectors, such as the LGBTQ community, about addressing systemic issues.
I've just been typing away over here. I wasn't quite sure how to address this topic, but as everyone has spoken, there have been, I think, more and more sort of pieces that are relevant, so I'm going to reflect on that a little bit. I first want to note I'm a professor of social work. Can you hear me okay with this on? Okay, great. I'm a professor of social work, so I wanted to briefly boost the comments about training social workers who are on the front lines of patient care, navigating administrative burden. Many are working in schools, and yet there are few social work schools across the country with dedicated courses on developmental disabilities. So I think that this is really an area where investment could be powerful. I know that my students, even if they end up in my class because it fits with their schedule and they do HIV outreach or substance use treatment or whatever, they quickly realize how relevant it is for them. So to this topic, so this is about learning from different communities. What can we bring from other communities into the work on aging and autism? And I'm going to focus on LGBTQ people, but I want to note, our friends from the deaf community here. I would love to hear from you. I know there's been a lot of investment on Down syndrome and Alzheimer's disease. I think there's probably a lot of sort of cross-disability work that we could learn from. So just noting that. So we know that there is a high degree of overlap between sexual orientation and gender diversity and neurodiversity. Both autistic people and LGBTQ people experience heightened rates of adverse experiences like abuse, bullying, and relatedly mental and physical health conditions. We have some emerging data that LGBTQ autistic people at the intersection have even higher rates of mental and physical health conditions. So I've done some work with researchers at Kaiser Permanente, North California, and a group of autistic, queer, and trans collaborators to compare medical records for people we identified as LGBTQ versus people who we didn't identify as LGBTQ. And we found higher rates of pain conditions, including not otherwise specified, migraines, nerve pain, GI conditions. But we had few older adults in this sample, which you sort of might expect, right? So we couldn't truly investigate rates of things like cancer compared, across those groups, or cardiovascular conditions, which we know are elevated for LGBTQ people, both due to stress, as we've talked about here, and due to mistreatment or just the fear of non-affirming care, right? So the people at my medical practice are not going to use my correct pronouns. They're not going to be able to provide the care that I need. And so, that can cause people to sort of shy away from preventative care and medical care altogether. So I also just want to call out here that those higher rates of pain, I think chronic pain is what a lot of people experience, right? So we talked about Ehlers-Danlos. We also saw higher rates of fibromyalgia, things like that. A lot of us are going to experience chronic pain at some times in our lives, and pain is right there in the diagnostic criteria for autism, yet there is not a lot of research on this right now. So I think that's an important place for some investment in understanding what is the diagnostic process like for chronic pain for autistic people, and what is the treatment experience like. So we've already begun to learn from LGBTQ scholarship. I want to give big props to Monique Botha, who was the first to extend this concept of minority stress to autistic people. And minority stress is a term we use to think about the ways that people are treated unfairly for who they are. We have a lot of evidence over the past 3 or so decades showing that at different levels, whether it's discriminatory laws or interpersonal experiences of rejection, these all can have effect on people's health. And I think what Dina said about those many small stresses adding up to something more impactful really sort of resonates with that. There's also a complementary theory developed by Lisa Diamond at the University of Utah called social safety theory. So this is this idea that all of these stressful experiences together can lead to a sort of constant hypervigilance to rejection, microaggressions, overwhelm, whatever it is. And what can moderate the effect of these minority stresses on health could be, do you have a place to go in your life where you can authentically be yourself and you know that people will have your back? So if you think about what we know about evolution and loneliness and you know, the importance of not getting injured by yourself in the jungle, for example, you can imagine that this is a powerful way for our brain to protect us, to be hypervigilant, but it also sort of shuts down the things that our brain could do if it weren't hypervigilant. So I think a lot about how can we communicate to people this acceptance, right? How, you know, we have rainbow flags. Many of you may have, you know, small something in your office or on your person that shows that you're an ally to LGBTQ people. What can we bring from that into the world of autism? Turning to aging, I just want to comment that both the LGBTQ community and the autistic community have had to find ways to thrive in systems not built for them, right? I think one of the most powerful lessons from LGBTQ plus aging is how people are often out of contact with their biological families. And so they create chosen family. They create mutual care networks and affirming spaces when traditional supports aren't as reliable. I think that autistic adults often face the same challenges as they get older, right? How to build support structures that don't depend on a system that has historically misunderstood them. Another parallel, I think, is disclosure. So LGBTQ people talk about coming out as an ongoing negotiation throughout the lifespan. And I think autistic people often describe something similar. There's masking, unmasking, deciding when to disclose, when is this going to be helpful for me, when are people going to hear me, but when am I going to hear, well, you don't look autistic, right? So this is also something, a sort of tension that both groups carry into later life that I think can shape health and relationships and dignity. And finally, I think aging isn't just about decline, it's also about continuity of identity. And many of us, I think, are sort of pulling those strings of identity together to really understand ourselves over the course of our lives, right? And so I think LGBTQ elders have shown us how critical it is to remain visible, proud, to show, you know, positive aging, and to provide mentorship to LGBTQ youth. So there's a lot of, you know, scholarship on these relationships with elders and how it can help youth who are struggling, you know, in those first years of coming out and feeling rejected, et cetera. And I think that also gives people a place to contribute that is really powerful. So I just want to open it up and hear what people think about this. Thanks.
Thank you, Laura. Thank you for being part of my chosen family. I did want to connect Alistair's comment with yours in the sense that I think historically the scientific community has been sort of like, but we don't talk about politics. And I think today's events are telling us that we need to not be just talking about politics, we need to be making politics. And the idea that we can have an autism conference anywhere in the world without addressing policy needs is abhorrent to me. We have absolutely got to take the reins of that and start making policy changes. We tend to work from grassroots, from the bottom up, and we have to get to the top. We have to be in the forefront of this. I also wanted to talk about what you said about isolation and aging. And the word that popped into my head, I almost said it out loud, was, but we can't afford it, right? What can you do? I mean, name 5 things you can do tomorrow without using money to socialize, right? I mean, it can be done, but it's a really hard lift, even if there's nothing more than the barrier of transportation. You know, you can't afford bus fare to meet somebody at the park, you know, to play chess or something. And so again, I think that that's a policy dynamic. We need to stop financially punishing people so severely for their disablement that we create more disablement. Where it just, everybody's making money on autistic people, but the disabled people themselves. And that's got to change. We have to have at least an average quality of life. I don't know how people live on $900 a month Social Security in the state of New York. And then what happens is we have to start intersecting other agencies. So, you know, talking about problems with administrative burden, to live in New York, you have to have food stamps, you have to have Medicare, you have to have Medicaid, you have to know how to navigate all those systems, you have to get the diagnoses. And this is while you're disabled and probably in a worse burnout of your life where you wouldn't have asked for the help to begin with. So we really need to bring this army of systems navigators on board to expedite things. But we can't expedite when our Social Security answering service says it'll be 280 days before we open your case. Like, we've got to do something from the top down. The systems navigators are the bottom-up solution, but we have to get involved in policy work at the top level. And that's not the same as politics. That politics is involving parties. I'm not even talking about that. I'm talking about human rights, something we all unify on across party lines. Thank you.
We have a comment from Hedda online. I'm just going to paraphrase in the interest of time, but they wanted to draw attention to the other meaning of the term autistic space beyond what Dr. Doherty has shared. It was coined and defined by autistic communities since the late 1980s and has been used to mean social and community spaces where autistic people define the rules of interaction, not to do with clinics or medical settings, but spaces for interaction, learning, activism, and work. And that these are the contexts that define good life, including good aging for us, for them, outside the medical paradigm, and that researchers and service providers need to learn from those different autistic spaces. And one of the recommendations was the Autscape organization as a source of information about that concept. Any other comments?
Chris?
Sure, go ahead, Chris.
As a member of the LGBTQI+ community, is we create a feeling of unity. Like you said, a lot of us are disconnected from family members. We make our own families. The gay rights movement, the LGBT community, we had a common goal. We persevered through. We got to some form of what we wanted. But I think this also feeds in very nicely to when you were discussing, Kimberly, the benefits of late diagnosis or a diagnosis at any age. It's finding that community at any point. We hear stories of older people, coming out later in life. They had a previous life where they were married and children and that, and then as they've got older, they found themselves. And I think personally that just feeds into nicely about that, the importance or the benefits of the diagnosis of any age, and creating that holistic community with your peers, with your support networks. I'm fortunate that I've never had any negative outcomes when I've gone into an interview panel and think I speak quite openly. This is me. You like it, you don't like it. You hire me, you don't hire me. But this is me as a person. And that's from all the years of the LGBT community and the gay rights movement. And I think the autism community can learn a lot where we can collectively come together to find that common goal. Yeah, thank you.
If you have data on older adults, please ask about sexual orientation and gender identity. You wouldn't believe how many large national data sets don't have either an autism variable or a sexual orientation and gender identity variable. So please think about this, because aging could be different. And I also just want to call out, I think, what you and what folks online said about, I think there's a lot of power in being with people who are like you in different ways. And, you know, I create support groups about various things, and I always have an autistic facilitator there, and I wonder if I even need to be there, but, you know, there's always an autistic facilitator, and we have a lot of activities and stuff, but when I ask people what draws you to this, I think it's being with other autistic, queer, and trans people and knowing that my experience is shared. I have a pregnancy project right now too, and you know, I am just thinking about one person who said, I wish I had been able to be with other pregnant disabled people, you know, and I would have learned so much from that. She was, you know, having baby blues and having a lot of stress around adapting to parenting, and her doctors never thought to refer her to such a thing. So I just, you know, I feel like my number one sort of like recommendation in any assessment would be like, let's help find community. So that's what I want to say about that. Thank you.
So I think we're going to have to move on. We have Fakhri Shafai, who's, again, the Chief Science Officer at AIDE Canada, and Fakhri is going to talk about loneliness and social isolation.
Thank you so much. I appreciate everybody sticking to the time, so thank you. We've already heard multiple times throughout today the importance and the challenges associated with loneliness and isolation, and so we're going to crystallize that a little bit more with this final talk. Multiple studies exploring the perspectives of autistic seniors have reported that social isolation and loneliness are key concerns for neurodivergent people as they age. One of our previous think tank participants, Terry Robson of Alberta, Canada, has allowed me to share this excerpt of a quote. As we get older, the people in our lives who we relied upon, like anybody else, they do pass away. So what do we do when we run out of people who can help us? Then we are left living a life of isolation, and that is one thing that scares me. These fears of loneliness are echoed in other studies where some autistic seniors report that they do not know who can support or advocate for them to have their needs met if they do need to move into an assisted living situation. While this is not available across the world, such concerns are being discussed in Canada actively, whether proposed changes in the medical assistance in dying or MAID criteria will lead autistic people to pursue MAID, not because of imminent pain, death, or suffering, which is the aim and intent of this care option, but rather as a way to escape the loneliness and loss of human connection. Many autistic voices resoundingly argue that this would reflect a failure of social and health services and core community gaps, and would not be considered by these individuals if they had the supports and community that they need. So the question I pose to the members of this think tank and to those attending around the world, how do we create a supportive community for autistic seniors? How do we make sure that Terry and other autistic people like her no longer have to fear social isolation and loneliness as they age?
I think we had a question from a guest, and then we'll take Bob.
Hi, everyone. I wanted to share, based on some of the discussion that's been taking place in the room. I study social work myself, and so I was thinking about training for social workers. I work with those who are deaf, who are autistic, those who are disabled, and knowing those communities, a lot of them are under-resourced. So maybe a deaf autistic person is seeking help, but their provider is hearing and doesn't understand all of their identities, and so gives them the wrong information and doesn't get them the help they need. We need to improve training and services for all to ensure that all are less isolated. You mentioned that those who are aging typically become more isolated. Those who are autistic also do, and then those who are deaf then can become 3 times as much. And so we want to make sure that all of those who are in the autistic community get the services and help they need for all their identities. Thank you.
Challenges that I face with aging autism families is how to help them think about what are the next steps and how they move along. And I don't find many resources that help me with that. So I can think of a lot of families that I've known for a long time where the parents are getting older and it's clear that they might be moving on, and yet they feel really committed to their child, and they want to keep their child living at home, and they want to find good arrangements, and the child, who's not a child now, is maybe 50 or 60, says they're comfortable at home, but somehow by being at home, their social skills have become less and less. So they're not as capable in moving into a group home or living with somebody. And then when the parents finally can't do it anymore, then it's just kind of a tragedy. And I don't know well how to help them. I don't know even something to encourage them to read, or, you know, where could they go to do that? I think of one person that I've known for a long while that I like, a dad who has a child that's quite impaired by autism and intellectual disability, and he lives at home, and this man is quite wealthy, and he can hire a round of people that come in and be with him, but the boy never makes any other relationships than those people that come in and be with him. And when I talk of maybe he could move into a particular living facility, and even if he used all of his money to make it so 10 people could live there with him, he'd have a community. And no, I've always been committed to my son, and I'm not going to quit now. And I don't know if anybody has any advice or a reference, or where can I, you know, suggest people read and think about this.
I would say the ARC network here in the U.S. Is often pretty well versed on helping people with dual identities, with intellectual disability and autism. We still don't have a solid resource for people who don't have intellectual disability, for people who are perceived as having lesser support needs, but they have support needs that are unaddressed. And there is a huge void there. Thank you.
Address the point that you made about training, particularly in social work, and not just in social work, but in all fields, right across the board. We need to raise the profile of autistic professionals. We need to change the culture so that autistic professionals are safe to disclose, and because for many it's simply not. Because that's how we raise awareness of autism, you know, in all fields. So even in social work, we've just written up the autistic space framework for social work, and we've published it in the Practice Journal, and that project was led by an autistic social worker, Jenny Guthrie. We've also done similar for education as well. That was led by Elaine McGoldrick, an autistic teacher, autistic space for inclusive education. But it's the value of insider perspectives right across the field. That will just help everybody to understand the needs of autistic people at all ages.
Yeah, I just have, because I see in where I live, there are adult daycare centers, and they are like, these are the elderly people who are not ready to go to assisted living, or they can still function. And they get a free transportation from home to the center and back in the evening, like 10 to 5. And so in that, it's all covered by the funds from the government and even insurance companies. So in that line, and they have, like, as far as I know, they go and play, even ping pong, that improves the hand-to-eye coordination. So it helps, and they have the social activity. So in those lines, can something be done for, like, autistic population, and like if the grant is somebody writes a grant, there are funds available, but the resources are there, but nobody knows about it.
Yeah, in terms of your question, Bob, about future planning, this is a widespread problem, and I can quickly mention 3 resources. One is Tamar Heller at the University of Illinois at Chicago has developed a program called The Future Is Now, and this is a training program for small groups of parents and family members. The autistic adult participates as well to put together a future plan. That's one. Any agency can get the manual and set that up. Another, the ARC has been mentioned, and in particular the ARC of the United States has an online toolkit for future planning that anybody can just go on there and do it. And in terms of those with autism without intellectual disability, the Association for Autism and Neurodiversity does a lot of online programming that are kind of webinars for families and individuals to do future planning. So there are resources out there, but they're not commonly known. That's the problem. Yeah.
I just wanted to jump back to Mary's comment around empowering medical professionals with disabilities to self-disclose. And one of the things that's been really nice that's happened at the organization that I work at is the development of a disability employee resource group called the Disability Employment Inclusion Alliance, that I have 2 colleagues with disabilities that lead it. And they're also working to, so it's, it's a space where people come together regularly to build community, but also to discuss the challenges within healthcare of people with disabilities. And we also have a disability council that I help to lead with these 2 other colleagues, where people from the ERG also kind of cross through that council. So I think about this in that, just that value and importance of building these community spaces, and to the point around, to your point too, around, I wonder about existing spaces already in the community that maybe just need to be accessed or designed a little bit differently. So in the town I live in, we have the Center for Active Living that's like a senior center, but there's, sports access, there's rooms. But as far as like who owns that, it's kind of like our recreation department. So it's like, okay, maybe it's like town recreation departments that need to be educated on autism or other disability groups to then pull together a disability, community space, once a week at the Center for Active Living. I'm volunteering myself in my town. No, but you know what I mean? But I think I wonder about like kind of things that already exist that we could be taking better advantage of for building community. So, thank you.
Fakhri, go ahead.
Echo what others in the room were saying about some of the challenges associated with creating these sorts of groups. And Laura, what you brought up about creating those social groups in your community are something to strive for, absolutely. But Dina, you brought up a really good point that a lot of these groups require funding of some sort, and in some cases there is funding available, and in some cases there's not. In Canada, I know a lot of people are able to access the Handy Dart system, so that covers the transportation piece. They'll pick you up and they'll take you somewhere, but a lot of these groups don't have a space to meet, so they meet at a coffee shop. And if that suddenly becomes a barrier for you, it can be a challenge. I know Autism Edmonton in Canada has done some great work with specific seniors groups for autistic seniors that are showing some great success.
Okay, well, I think I'm going to turn it back over to Stephen Edelson to wrap us up for today.
So thank you, Fakhri. Thank you, Vanessa. Overall, I think everyone here is quite happy with what transpired. So as we come to a close to the think tank meeting, I want to take a moment to reflect on what we have accomplished together today. Over the past 3 hours, we have explored many important topics, each one shedding a light on the complex realities of aging with autism. We have heard from autistic individuals themselves, from families, clinicians, researchers, and advocates, each perspective adding a vital thread to the larger picture. What has been most striking is not only the challenges we have identified, but also the opportunities. We have seen how aging and autism intersect in ways that demand new approaches in healthcare, long-term care, and social inclusion. We've also seen how much remains unknown and how urgently research and policy must catch up to meet the needs of these emerging issues. But today has reminded us that progress is possible when diverse voices come together with openness and commitment. This gathering was designed to be more than just a meeting. It was meant to spark dialogue, collaboration, and new connections. The ideas shared here will not stay in this room. They will help inform future research, guide practice, and inspire advocacy so that autistic seniors are no longer overlooked, but instead are supported, respected, and celebrated as valued members of the community. I want to thank each one of you for your insights and your generosity in sharing your experiences. The richness of today's discussions came from the willingness of everyone here to listen deeply and to speak honestly. That is the spirit of a true think tank, and it is how lasting change begins. So thank you.